Good morning, everybody, and happy Thursday. We are excited to have a great session presented today on sepsis and the impact that has in our healthcare centers as we continue to move forward and navigate through the post-pandemic world. It's a great opportunity for us to get back into what was old is new again, back into these practices that really help the outcomes of our patients and our residents. As we look ahead, I do want to highlight some upcoming sessions that would be of interest to you, and to remind you that we do have this session archived on our YouTube channel. So any session that you may miss, you're able to go into our YouTube channel, open that up, and access that information. We've had some amazing speakers with great information to help us with our policies and practices. Next week, the 3rd, August 3rd, so it's not on our routine schedule, we are doing a special free CE event. So you'll be able to obtain one CE at no charge. That's currently available to nursing home administrators, nurses, and social work. So it's a great opportunity to learn about infection prevention as we are coming into flu season. Getting our standards in place for that, and preparing, and also earning that CE that's necessary for our licenses and continued program support. We'll have Evelyn Cook of SPICE Infection Prevention sharing the elements of performance. Again, a great opportunity to take a look at if we're ready for flu season, as well as to ensure we're ready for surveys to come in and be compliant with those guidances. You'll have to register special for that event, and I have the link that I'll place in the chat box once we get started. So please take a moment to register for that event. All we ask is some 5-question information before you can get that CE. So super easy. We're just trying to understand what the numerator denominators are for the infection prevention training that you've completed this year for active employees. So I think it's an easy, fair trade-off. Other great sessions have been coming up. We've got some wonderful work from the Leadership Academy. They'll be updating on best practices on staffing and staffing retention for frontline caregivers, a very critical topic for many of us. Cindy Frakes is coming in on September 14th. She is from the National Association of Healthcare Assistants and leads the NICE program through them. She's going to be talking about how we incorporate the facility assessment tool into an organizational strategy. So not just keeping it as a task, but also using this as a strategy and a planning tool to be able to do operations and plan for the future. So it's a good opportunity to take that task-based function that we see and really operationalize it for a better outcome. And we have Julia Brooks coming in on maintaining an effective skin program. Skin is one of the top 10 citations that we're seeing being given in the state. And so it's a good discussion on looking at the skin program, the considerations, and ensuring that we have those pieces in place for survey preparedness. With that, I want to thank you for your attention today and want to introduce our fabulous co-workers here at Constellation Quality Health, Sarah Banyai and Kris Williamson, as they produce and present the sepsis work group information. Thank you so much for joining us, ladies.
Thank you. Give me 1 sec to pull up our slides.
Okay. All right. So good morning and thank you for having us. As Melissa said, I'm Kris Williamson. I am a quality improvement specialist that works with the long-term care community here at Constellation Health. For those who are unaware, we have had some changes in the last couple of weeks. CCME has rebranded and is now formally known as Constellation Quality Health. It's still the same people, it's still the same work, but we wanted to make some changes to be indicative of the new breadth and scope of the work that's being done. We are a partner of the HQuinn group. HQuinn is a 4-state collaborative that covers Kansas, Missouri, Virginia, and South Carolina to work under contract with Medicare to provide healthcare quality improvement assistance. Sarah, if you'll move on. So today we're going to talk to you about sepsis. And, you know, we all have heard of sepsis, but what is sepsis? And next, sepsis is not a standalone disease. Sepsis is something that comes in collaboration with something else. It's a infection plus something more. So basically, once a infection has taken hold in the body, then it moves on from its original site into something more in the bloodstream, and the body has a very strong response to it. It is very serious and it can be fatal. It very often is. So it's not the original infection, but a reaction to an infection that has moved on and can quickly impact organs and tissue. Sarah, if you'll go ahead. Okay, so those most at risk, there are some variances in the literature, but this they agree upon people over 65, and it would seem that as you get a little older, your risk increase a little more. And so it does move up and down a little bit. People over 65, babies under a year old, those immature immune systems, you know, those who have suffered burns, trauma, have serious wounds, those with catheters. Remember, we said that sepsis was not the initial infection. Catheters are an entryway. They are a freeway directly into the body that is very often responsible for infection. That's why it's so important to ensure that you're using proper aseptic technique when you're inserting or doing catheter care. Chronic disease, kidney disease, cancers, diabetes, liver conditions, AIDS, those folks, their bodies are already under assault. And so they have weakened systems, and people that are fighting, you know, cancers, people on chemo, those sorts of things, those things diminish the body's ability to fight. And so those people are very much at risk. And I think we can all agree that that means that our nursing home community is, after all, at higher risk than the standard. There is some literature that speaks to those that are 80 being at doubly increased risk. So that's something to think about as we move forward. Why should you be concerned? Well, 270,000 Americans die from sepsis each year. It's the leading cause of admissions from nursing homes. 15 to 50% of the people who are admitted to acute care hospitals who are diagnosed with sepsis will die. And there are a lot of secondary things that, should someone survive the initial sepsis event, they will die of post-sepsis syndrome, which is inclusive of a lot of things like heart attacks and liver damage, those things, kidney failure, because those organs have already been damaged and have not returned to their standard. So sepsis kills, and post-sepsis syndrome may kill them within the year. Quick recognition of infections and early warning signs are the key to survival. And so that helps prevent severe sepsis and septic shock. I'm going to hand it over to Sarah, and she's got some more data for you that is both national and South Carolina specific. Sarah?
Thank you, Kris. So as we've been talking, you know, like Kris kind of said at the beginning, it's a good time to get back to some processes we had in place pre-pandemic. Maybe things are calming down a little bit and we can go back and reassess. And that's kind of what we've been doing at the QIO. We've been looking at our data. So we get Medicare Part A claims data. And one of the things we've been looking at is high utilizers. So that's people who go to the hospital 5 or more times a year. And as we were digging in our data, we kept seeing sepsis flagging as the reason people were ending up back in the hospital. So as we kept digging in our data, we're like, what's going on? How can we address this? And how can we improve those rates in South Carolina? So I'm going to go through a few slides on some of the data we found to kind of give you an idea of what we were seeing and why we thought it was important to start talking about this. You know, maybe we're at a place where we can look at some opportunities to look at maybe some of our sepsis processes and protocols in our facilities. So this is data from the CDC about sepsis mortality by state. South Carolina is 40th out of 50. And while the 2021 death rate is 12.7, that is an improvement from 2020, which was 14.5. But, you know, being 40th in the country, there's still room for improvement. So this was kind of one of the first things we looked at, saying, okay, well, what's going on? So then once we kind of got a feel for like, oh, maybe sepsis is a larger issue than we were thinking, we started digging more into our data and looked at the top diagnoses for inpatient admissions among high utilizers, like I mentioned. And you can see it is sepsis by 2 times any of, you know, the second, the hypertensive heart and chronic kidney disease, the second diagnosis on our list. So that gave us pause. And we were like, maybe we need to dig more and look into what's going on and how we can address this in South Carolina. Similar, the top DRG code for all populations, not just the high utilizers, is also sepsis by, you know, another half over heart failure. So we do a lot of focusing on the chronic illnesses and chronic disease, but this data led us to believe maybe we need to look more at infections and possible sepsis, early warning signs and symptoms, and just maybe it was time for a refresher on some of those things. Similarly, here's the DRG codes for high utilizers. Still sepsis. And here's the SNF, top principal index discharge diagnosis leading to readmission, sepsis by 4 times. So it's, according to the data, sepsis is predominantly community acquired before it ends up in the hospital. So early warning signs and symptoms are imperative to quick and effective care. So we also looked at the readmission volume by days once a sepsis patient was discharged to a SNF. So once that patient ends up in your facility, you know, they've been in the hospital, they were very sick, and it's just so important to pay attention to that first week, kind of what Kris was talking about with that post-sepsis syndrome, at opportunities to keep them at their levels, or making sure we're doing a little extra vigilance to ensure they're, you know, if they need to go back to the hospital, we can get them back to get that care they need, or just, you know, that because small conditions, the small changes in condition can really make a huge difference, especially for septic patients. We also looked at infection-related hospitalizations by type, not just sepsis, but also looking at UTIs, COVID, and pneumonia. And I don't think it's a surprise to anybody to know that if someone goes to the hospital with one of those, more than likely they're going to have more than one, particularly with sepsis. And sepsis is infection plus. There's that underlying infection that then is exacerbated into those other sepsis symptoms, which we'll talk about in a little bit. But just to kind of be aware, if you have a patient that is maybe presenting with some pneumonia symptoms or some UTI symptoms, you know, maybe that's the kind of patient or resident you also want to think about looking at some of those sepsis indicators. So just kind of an awareness. Okay, well, you know, we know there's a UTI here, but also is it worth looking at maybe some of these other things, or at least having them in the back of your mind, so that if you start seeing some, you know, a very fast decline, you can get them that care they need quickly. Because similar to stroke, you know, with the acronym FAST, sepsis is one of those, if you suspect it, you got to get those antibiotics quickly to have a better outcome. It's kind of what Kris was talking about with those high death rates, is the sooner they get the care, the more likely they are to have better outcomes. So that's a similar kind of opportunity. And we also looked at the infection-related hospitalizations by the infections, just to kind of give us a complete picture of who was ending up back in the hospital or ending up in the hospital as a result. And I don't think it's a surprise that sepsis, being a little bit more severe than your typical infection, was leading to a lot of hospital admissions. But just wanted to show we're seeing it in the short stay residents and the long stay residents almost equally, you know, not a huge difference in those two scenarios. So it's just another point to say it's so important for those early warning signs and symptoms to have awareness of them, and then a plan of action if they are suspected, which we will get into in a little bit. This is our hospitalizations related to facility acquired infections for short stay residents. And this is a great slide. Rates are going down at a steady rate. The hospitalizations are looking good, and this is all South Carolina claims data. So this is looking this is a slide we're very happy with. Like, things are looking good. People are on it. The hospitalization, you know, people are able to take care of their residents in-house. Same thing with long stay. However, when we break it down at sepsis specifically, we're seeing the opposite. So just another kind of point for us to want to do a little bit more around sepsis education. And one of the reasons we wanted to have this discussion with you all today about what's going on. You know, our data is showing this, but are you seeing this too in your facilities? Because, you know, claims data is great, but it's not the whole story. You know, we like to use it as a starting place for a conversation around what's going on. How are you addressing things? What do you need to make the identification easier, or a process workflow more standardized? So are there opportunities based on the data that you're seeing? Or are you just like, sepsis is not as big of a deal in your, like, are you not seeing it? So it's just, you know, we like to use this because this is all statewide data. We have broken it down by facility specifically, but this is just kind of an overall picture. And like I said, it's a good just starting place to have a conversation, which is what we would like to do today. And similarly, as short stay, long stay, also sepsis rates increasing. And I will turn it back over to Kris to talk a little bit about the early warning signs.
Hi. So we already discussed, you know, these folks have already got some sort of infection, and there's a chance that you may know that. But the fact is, there are occasions when the sepsis will come on so quickly that they don't know where the primary infection was, because the sepsis has pretty much overwhelmed the body. So what you see here is kind of intimidating looking, you know, and this is one that is available out there publicly that anybody can look at, that says that this is the ED sepsis cheat sheet. And the primary things that you're going to see when you're talking about your resident in the long-term care center, the first thing you're going to see are these things in the middle. You know, their temperature, their heart rate, their respiratory. So, Sarah, if you'll move on to the next one. Most people in long-term care centers are not going to be paying attention to the last slide. This is the things that they see. If the patient has a suspected infection and has a temperature over 100 or less than 96.8, if they've got a pulse over 100, if their blood pressure is less than 100 or greater than 40 from their baseline, because, you know, some folks, their blood pressure is low all the time, you know, and let's be honest, a lot of them are laying down. So that makes a difference too. So think about your baseline and a shift from your baseline. Their respiratory rate, if it's greater than 20, you know, then we're we're looking at that. And think about their pulse ox. You know, I know that in a long-term care center, you may not have the ability to do a CAT scan, but you can do a pulse ox. And your pulse ox at less than 90, they don't have the oxygen carrying capability that they need to be able to feed their cells and fight. So that respiratory rate is a big deal, as is that pulse ox. But here's the thing. Sometimes you won't notice these things as much as you will that last piece. And your CNAs are a big part of the care at this point. They spend time face to face with your residents every day. Your housekeepers and environmental services folks that are in your building consistently spend time in their rooms. They know your residents. They know that this is not their normal demeanor. If you see an alteration in their normal, from their normal, then that's something that should send up a red flag and cause you to look a little closer at other things. And it may be that your CNA goes to you and says, you know, I don't know what in the world's going on with him today. He is just ill as a rattlesnake, and he is normally so laid back. That little observation should be something that causes you to think twice. Is there something more going on? So I've got the link for that down here at the bottom. And on a lot of resources that we have, you'll see those. So Sarah, if you'll move on. We have for you something called a post-acute care sepsis cheat, fact sheet, I think it's called. Fact sheet, there it is. Sorry. But it talks to you about the signs of sepsis. And this is something that you can download from the website. Again, the link is there. And it's something that you can laminate and put up in your med room, in your break room. Have your staff be aware. It's something that's very friendly as far as the reading. You know, what are they shivering? Are they complaining of pain? Are they sleepy, pale? Do they have a feeling of doom that I'm going to die? Something bad is happening. Are they short of breath? And so, you know, there are things that help you to prevent this. Hand hygiene, and I know we beat hand hygiene, you know, we say it every week about something. Hand hygiene is such a big piece. It allows us to to break the chain of contagion. And so hand hygiene, vaccination, clean wounds. Wound care is a big deal. And knowing the signs and symptoms of sepsis. Once you establish that there is something going on, that something isn't right, you know, have a comprehensive, consistent plan in place to communicate those changes in status and communicate them effectively to your providers, because they are the ones that you're going to have to talk with. You're going to have to be able to tell them what's going on. If you have the ability to do IVs and get fluids into them, you're in a much better position. That puts them in a better position for later on, because every hour that antibiotics are delayed, they suffer a much greater risk of mortality. There are studies that say as much as 10% per hour. And so, you know, that's a big thing. So if you can get that going while you're waiting on EMS or whoever, and that's the thing that the EMS folks talk to us about on our care coordinators meeting, that very often we have to consider that sepsis is an emergency. It's not a sick call to the doctor's office. It's an emergency And so you need to call EMS for sepsis or suspected sepsis rather than calling your regular transport service. So this is not a scheduled transport. So we've got some steps here to prepare, prevent, screen, and Sarah's going to give you some tools to talk about with those. Knowing the signs of sepsis, being able to communicate them effectively and move the resident to the most appropriate level of care is the key. So, Sarah, if you would, I believe that's it. I'm going to turn this over to Sarah. We've given you some information to you earlier. This very, a very informal program. And if you've got questions, we would love for you to come off mute and share those with us. If you're not comfortable in doing that, if you want to send us a message, drop something in chat, we'll be happy to have that. So, Sarah, if you would.
Thanks, Kris. So, so we assessed some nursing homes a few months ago and asked them, are you tracking your sepsis data? Are you looking at sepsis patients? And the majority of them told us they were, which is wonderful. So, but maybe it just wasn't a good time to look at those processes or those workflows for standardization. But we wanted to share some tools and resources that would help to kind of go through that process for nursing homes and facilities that are in a place to maybe and are seeing maybe some sepsis in their facility, that where these tools might be a helpful place to start. Because yes, awareness is important, but like Kris said, then what? So how do you standardize something within your facility? So we have a nursing home sepsis gap analysis. It helps a facility assess their current levels of sepsis care and identify any potential gaps. So you could look at this. Do you have education? Do you have an in-service training? Do they get training upon hire? Or just are there opportunities for is there a plan in place, I guess? Or if you have a plan in place, is it comprehensive? So it's just kind of a good place to start to figure out maybe what you can do to enhance your current program or process. Once you've done your gap analysis, you might say, okay, well, we've noticed some areas that could use some improvement, but now what? So we also have this action plan template that will help you kind of conduct that root cause analysis, really get down to the main factors contributing, continue to identify areas for opportunity. You can set a SMART goal. It will help you establish your, give you some steps for establishing your multidisciplinary team and then determining those next intervention steps to have a comprehensive, standardized care path for potential sepsis residents. We also have this sepsis risk assessment evaluation tool, which goes through your organ systems. So once a patient, so let's say your resident or a patient was discharged to you, this new resident comes in. This is just a good checklist to go through and determine if that resident might be at a higher risk for sepsis so that you could flag them in the chart. So just to keep an extra eye on maybe they had a surgery and you want to make sure that surgical site isn't infected, or maybe, a recent UTI or certain issues that you just want to kind of flag for a little bit higher level of observation so that if there are signs of sepsis, or, if they're a sepsis patient and you're looking at that post-sepsis syndrome, you can flag that and then get them the care they need quickly. Like I said, you can do it on a pre-admission based on what you get from the hospital, or it could be completed during rounds after that patient is admitted. And then once you've done that and you've flagged a few patients as potential higher risk for sepsis, there's also a high risk rounding tool that you can use to help follow that patient for a few days or a week, because as we showed in that histogram several slides ago on the data, that first week is so critical to keeping that patient out of the hospital. So this is just kind of a good way to systematically think through, is this patient at a potential higher risk for sepsis. So like Kris said, we've talked about those early warning signs and symptoms, but then what? Then maybe you do some of the criteria, you check their pulse ox, you check that blood pressure, but then what? What should you do? At what point do you notify a physician, or at what point do you do some extra screening? And this is just an easy algorithm that kind of helps you take those signs and symptoms and decide, is this potential sepsis and we need to move quickly, or is it something we can just monitor in-house for a little bit and determine what steps make the most sense to care for that patient. It's just kind of an easy cheat sheet, your yes, no, your care path of when to involve, when to transfer, when to maybe notify the provider, just kind of a good way to talk through what that process looks like to get a resident the care they need. We also wanted to share a bunch of resident and family resources because since sepsis is, if you see something, say something, it is a medical emergency. The faster you get treatment, the better your outcomes. It's important for everyone to know the signs and symptoms of sepsis, not just the people working in your facility, not just nurses. It should be everybody should have basic training on what those signs and symptoms are, because anyone could notice a change in the condition of a resident. Maybe they're not eating as much. Maybe, little things that can be those early identifiers, which could get the resident the care they need as quickly as possible. So it's also important to, have the families and everyone in your facility having a little bit of basic education on those early warning signs and symptoms. So I wanted to share some, we have another fact sheet that's a little bit more resident family focused about sepsis as a medical emergency. There's also the sepsis stoplight tool, which is good to kind of talk about those signs and symptoms and at what point should I really, call 911 versus just calling my doctor versus, just wait and see. And then kind of like I mentioned with FAST, the stroke, or mnemonic device for signs and symptoms of a stroke, sepsis has time. So can remember things to watch out for: temperature, infection, mental decline, and then that extreme severe illness, discomfort, that level where you feel like you're gonna die. Because that's, when we've talked to people who've had sepsis, that's one of the things they say is like the sickest they've ever felt, the worst flu they've ever had. So just some easy kind of tools and resources that you could hand out, that you could post in your facility, that are just colorful and catch people's attention and just gives them some of that basic knowledge so that they could, say something if they notice some of these signs and symptoms. And lastly, we wanted to talk about, so this is a really good kind of lead up to, we are launching a sepsis sprint series starting in September. It's going to be every other Wednesday. We're budgeting 30 minutes, but we're hoping to keep the presentations really short and succinct, about 15 minutes, just to really give you the, a really quick detailed presentation, give you one or two tools, and then, you can go work on those one or two things. Whereas this talk we've been having has a little bit more been focused on like those internal processes. What are you doing within your facility? We're also going to get into some of that critical communication and the transitions of care. How do you notify the hospital? Kind of like what Kris was saying. When do you call EMS and get them involved? When a patient is discharged after having sepsis, what does that look like? So really talking through some of those coordination pieces with other providers. When do you get your physician, your PCP or your patient resident's PCP involved, your primary care physician, and just really talking through what that transition looks like, what's that communication look like, how can you standardize that communication, what does the hospital need, what do you need? So just really talking through giving all those details, because it's so imperative, as we keep saying, it's a medical emergency, the faster the better. So if you can have something in place where you can provide all the necessary information, once they get to the hospital, they can really get going with that IV or that antibiotic or if it hasn't already been done, then that's just, you know, leads to better outcomes for patients and residents. So if you're interested, you can register for these sessions. We hope to have some really robust discussion and talking through a little bit more of some of those workflows and more of the communication involved with other providers as well. So with that, if there are any questions, please put them in chat. Or if you are interested in any of the tools we shared and would like to talk a little bit more about them, or you're thinking about adding some, looking at your sepsis processes or looking at doing a PIP plan around sepsis or something, please let us know if we can help. We are more than happy to talk through what you're currently doing and maybe some areas for opportunity to kind of standardize some of those pieces within your facilities. So please feel free to reach out to Kris or I, and we are happy to take any questions if anyone, if anyone wants to share what they're currently doing in their facility around sepsis. Are we just not at a place to focus on it at this point? Or are we starting to think maybe there's some, you know, we're starting to look at it, but just aren't very far in yet. So with all the emphasis on infection prevention, this just fits in very nicely with you know, kind of continuing that work. So I
noticed a couple of people were a little later to join us. And I wanted to make sure that we reiterated that this material has been recorded and will be available. And the link for that will be included in the post-event email that you get. So you will get that. We certainly thank you for joining us today. If there's anybody that is willing to talk with us regarding, you know, what they're seeing with regards to sepsis, I know we have a large number of folks on here from DHEC, and you go out into buildings every day and talk with buildings as we do. Are you hearing anything in particular with regards to sepsis that may be beneficial? Well, that being said, it looks like we're finishing up. And so thank you for your time. We look forward to having you with us. Every time we do this, we want to give you something that you can take away that's beneficial to you. You will receive a survey at the end, and we ask you to complete that for us so that we can determine whether or not what we've discussed with you today is valuable for you and how we might move this program forward. So Sarah, unless you have something else, we'll close out the recording and let folks go.
Thank you, everyone.
Thank you.